A hypertensive patient walks in. Exams don't ask what is hypertension, they ask which drug. Let's begin calmly. Hypertension is not just a number, it is a persistently raised arterial blood pressure. One high reading is not enough. Sustained pressure causes silent damage. That's why hypertension is one of the most important treatable causes of premature illness and death. High blood pressure doesn't shout, it whispers, and over time it damages organs. It increases the risk of stroke, myocardial infarction, heart failure, chronic kidney disease, and premature death. So treatment is not about a number. It's about protecting the brain, heart, and kidneys. Hypertension becomes more common with age, especially in women aged 65 to 74, and in people of Black African or African Caribbean origin. Lifestyle factors like poor diet, stress, and social deprivation also play a role. Now pause here. Exam point. Why do we treat hypertension? To reduce cardiovascular morbidity and mortality, especially stroke and myocardial infarction, by safely lowering blood pressure to target levels. Before drugs, we start with lifestyle measures. Exercise, healthy diet, reduced salt and alcohol, smoking cessation, and stress control are essential, with or without medicines. Now let's talk diagnosis, because this is where many students make mistakes. If a clinic blood pressure is 140/90 mmHg or higher, you do not label immediately. You must confirm it using ambulatory blood pressure monitoring or home monitoring if ABPM isn't suitable. This brings us to stage 1 hypertension. In the clinic, readings are 140/90 to 159/99 mmHg. On ABPM or home readings, the average is 135/85 to 149/94 mmHg. Now the key exam question, do we treat everyone with stage 1 hypertension? No. Drug treatment is discussed in patients under 80 only if risk is present, such as target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk of 10% or more. In adults under 60, even with lower risk, treatment may be considered. In patients over 80, treatment is considered if clinic BP is above 150/90 mmHg. And a very important line you must remember, patients under 40 with stage 1 hypertension should be considered for specialist assessment because we must exclude secondary causes. Sign guidance is stricter, recommending treatment above 140/90 in high-risk patients, regardless of age, and even in normotensive patients after stroke or TIA. Now, stage 2. Clinic readings are 160/100 mmHg or higher, but below 180/120. ABPM or home averages are 150/95 mmHg or higher. Here, there is no debate. All patients with stage 2 hypertension must be treated regardless of age. Then comes severe hypertension, systolic 180 or diastolic to 120 mmHg. This requires prompt action. Same-day specialist referral is required if you suspect pheochromocytoma or if BP is 180/120 with retinal hemorrhage, papilloedema, or life-threatening symptoms like confusion, chest pain, heart failure, or acute kidney injury. If there are no symptoms, you urgently assess for target organ damage. If damage is present, treat immediately. If not, repeat BP within 7 days. Once hypertension is confirmed, every patient deserves a full cardiovascular risk assessment. This includes HbA1c, electrolytes, creatinine and eGFR, cholesterol profile, urinalysis, retinal examination, and a 12-lead ECG. Now targets, very exam-friendly. For clinic readings, under 80 years, below 140/90, 80 years or over, below 150/90. For ABPM or home readings, under 80, below 135/85, 80 or over, below 145/85. Sign prefers tighter control, especially when cardiovascular disease or organ damage is present. But remember, targets are adjusted for frailty and tolerability. Medicine is not rigid. Drug treatment follows principles you must respect. One drug is often not enough. Treatment is escalated stepwise. Drugs are titrated to the maximum tolerated dose. Adherence is checked at every step. Age and ethnicity matter. If an ACE inhibitor causes cough, switch to an ARB. Never combine ACE inhibitors with ARBs. In Black African or African Caribbean patients, prefer an ARB over an ACE inhibitor. If calcium channel blockers cause edema, switch to a thiazide-like diuretic. Prefer indapamide over conventional thiazides. Continue bendroflumethiazide or hydrochlorothiazide if BP is already well controlled. Now the classic treatment steps. In patients with type 2 diabetes of any age, or those without diabetes age 55 and not Black African Caribbean, step 1. Start with an ACE inhibitor or ARB. Then step 2. Add a calcium channel blocker or thiazide-like diuretic. Then step 3. Triple therapy, ACE inhibitor or AR plus CCB plus thiazide-like diuretic. If still uncontrolled, step 4, confirm BP, check adherence, assess posture, and consider spironolactone or alpha-beta blockers if potassium is high. In patients without diabetes age 55, or Black African Caribbean patients of any age, step 1, start with a calcium channel blocker. Then step 2, add ACE inhibitor, ARB, or thiazide-like diuretic. And step 3, triple therapy. Step 4, as above, with specialist input if needed. Hypertension and diabetes deserves respect. Good control reduces macrovascular and microvascular complications. In type 1 diabetes, targets depend on albuminuria. Always start with a renin-angiotensin system blocker. Do not fear beta blockers if indicated. Use only long-acting calcium channel blockers. Type 2 diabetes NICE uses the same targets as non-diabetic patients. SIGN recommends treatment above 140 mm Hg systolic, aiming for 130-80 mm Hg. In renal disease, treat aggressively but wisely. Targets again depend on albuminuria. Once daily dosing improves adherence. In pregnancy, hypertension affects up to 10% of women. Every pregnant woman with hypertension needs specialist care. First-line drug is labetalol. Alternatives are modified-release nifedipine or methyl-dopa. ACE inhibitors, ARBs, and thiazide diuretics must be stopped. Postpartum, enalapril is first-line if breastfeeding with close review. Now pause. If this felt long, remember hypertension is long-term, but you don't need to memorize everything at once. Understand the logic, the flow, and the why, and exams become easier, patients become safer, and you become a better clinician. Now, once the common first-line drugs fail, or when blood pressure becomes difficult, dangerous, or resistant, we move into a group of drugs that are powerful, effective, and therefore potentially risky if misunderstood. Let's start with vasodilator antihypertensive drugs. Vasodilators work by directly relaxing blood vessels, producing a strong fall in blood pressure. Because they act powerfully, they are almost never used alone. They are usually combined with a beta blocker to control reflex tachycardia and a thiazide or loop diuretic to control fluid retention. And this is a key clinical warning. Rapid blood pressure reduction can be dangerous, especially in hypertensive crises. Lowering BP too fast can reduce perfusion to the brain, heart, and kidneys. Hydralazine hydrochloride is one of the classic vasodilators. It is given orally as an adjunct in resistant hypertension, but today it is rarely used. When used alone, it causes tachycardia and fluid retention, which limits its usefulness. Sodium nitroprusside sits at the other extreme. It is given by intravenous infusion and is reserved for severe hypertensive emergencies where immediate parenteral control is required. This is not a ward drug. This is ICU-level medicine. Minoxidil is even stronger. It is used only in severe resistant hypertension. It causes marked vasodilatation, leading to increased cardiac output, reflex tachycardia, and severe fluid retention. Because of this, it must always be given with a beta blocker and a potent diuretic, usually high-dose furosemide. One unique adverse effect you should never forget, hypertrosis. Excess hair growth makes it especially unsuitable for females. Then we have drugs like prazosin, doxazosin, and terazosin, which act as alpha blockers and also cause vasodilation. These bridge us into the next important group. Now, a short but important detour, pulmonary arterial hypertension. Pulmonary hypertension is not treated like systemic hypertension. Drugs such as ambrisentan, bosentan, iloprost, macitentan, sildenafil, and tadalafil are used, always under specialist supervision. Epoprostenol is reserved for primary pulmonary hypertension that is resistant to other treatments. Bosentan has an additional indication. It reduces new digital ulcers in systemic sclerosis. Riociguat is licensed for pulmonary arterial hypertension and chronic thromboembolic pulmonary hypertension. And remember this clearly for exams. Cytoxan-10 has been withdrawn because of severe hepatotoxicity. Now let's come back to systemic blood pressure and talk about centrally acting antihypertensive drugs. These drugs work by reducing sympathetic outflow from the brain. Methyl-dopa acts centrally and is mainly used in hypertension during pregnancy. It's old, it's slow, but it's safe in pregnancy, and that's why it survives. Clonidine is effective but dangerous if misused. If stopped suddenly, it can cause severe rebound hypertension. Never forget that. Moxonidine is licensed for mild to moderate essential hypertension and is used when first-line drugs are unsuitable or ineffective. Next are adrenergic neuron blocking drugs. These inhibit the release of noradrenaline from postganglionic neurons. They do not control supine blood pressure and they commonly cause postural hypotension. Because of this, they are now rarely used but may still appear in resistant hypertension. Guanethidine monosulfate is licensed for rapid BP control but is almost never preferred in modern practice. Now let's slow down. This next group is very exam relevant. Alpha adrenoceptor blocking drugs. Prazosin blocks postsynaptic alpha receptors, producing vasodilation with minimal tachycardia. However, it has a famous problem, first-dose hypotension, so it must be started cautiously, usually at night. Doxazosin, Indoramine, and Terazosin have similar effects. These drugs are especially useful as add-on therapy in resistant hypertension. They also have another very practical role in benign prostatic hyperplasia. Drugs like alfazosin, doxazosin, Indoramine, prazosin, tamsulosin, and terazosin improve urinary flow while also lowering blood pressure. This dual benefit is not an accident. It's pharmacology helping real patients. Now we enter one of the most important systems in medicine, the renin-angiotensin system. ACE inhibitors block the conversion of angiotensin 1s to angiotensin 2. They are widely used, effective, and generally well tolerated. In heart failure, ACE inhibitors are used in all grades, usually alongside a beta blocker. Before starting, potassium supplements and potassium-sparing diuretics should be stopped. Low-dose spironolactone may be added, but potassium must be monitored carefully. First-dose hypotension can occur, especially if the patient is on high-dose loop diuretics. In high-risk patients, specialist initiation may be required. In hypertension, ACE inhibitors are preferred in younger Caucasian patients and in type 1 diabetes with nephropathy. Response is reduced in Black African or African Caribbean patients, those over 55, and in primary aldosteronism. They are also crucial in diabetic nephropathy, where they slow progression of renal damage, and after myocardial infarction, they provide long-term cardiovascular protection. But ACE inhibitors are not harmless. Renal function and electrolytes must be checked before and after starting. They increase the risk of hyperkalemia and renal impairment, especially in renal disease. They must be avoided in bilateral renal artery stenosis and used cautiously in suspected renovascular disease. NSAIDs increase renal risk. Potassium-sparing drugs increase hyperkalemia risk. High-dose diuretics increase the risk of severe hypotension after the first ACE inhibitor dose. Combination products with thiazides or calcium channel blockers should only be used after stabilization. When ACE inhibitors cause cough or are not tolerated, we move to ARBs, such as losartan, valsartan, candesartan, and irbesartan. They offer similar benefits without cough. In selected heart failure patients, candesartan or valsartan may be added to ACE inhibitors, but only under specialist supervision. Aliskiren, a renin inhibitor, is licensed for hypertension, but here comes a major warning. Combined RAS therapy using ACE inhibitors, ARBs, or aliskiren together is not recommended. It increases the risk of hyperkalemia, hypotension, and renal failure. Only selected heart failure patients should ever receive combination therapy under strict specialist care. Now, beta blockers. They block beta receptors in the heart, vessels, bronchi, liver, and pancreas. They look similar, but clinically they are not identical. Some have intrinsic sympathomimetic activity, causing less bradycardia and fewer cold extremities. Water-soluble beta blockers cause fewer CNS effects, but need dose reduction in renal impairment. They are contraindicated in second or third degree heart block and unstable heart failure. Asthma is a relative contraindication. Cardioselective agents are preferred if unavoidable. Side effects include fatigue, cold extremities, sleep disturbance, and masking of hypoglycemia. They are not contraindicated in diabetes, but caution is essential. In hypertension, beta blockers reduce BP by lowering cardiac output, suppressing renin, and central effects. They work, but they are less protective against stroke and MI, especially in the elderly. That's why they are not first line for uncomplicated hypertension, and never ever use a beta blocker alone in pheochromocytoma. Beyond hypertension, they are vital in angina, MI, arrhythmias, heart failure, thyrotoxicosis, anxiety, migraine, and glaucoma. Pause here and write down the important points from what we are talking about. These are the lines that decide your exams. Finally, calcium channel blockers. These drugs vary widely. We divide them into verapamil, diltiazem, and the dihydropyridines like amlodipine and nifedipine. Except for amlodipine, they should generally be avoided in heart failure. Verapamil is a strong negative inotrope. It's used in angina, hypertension, and arrhythmias. It causes constipation and must never be combined with beta blockers. Dihydropyridines act mainly on blood vessels. They are excellent for angina and hypertension, but cause flushing, headache, and ankle edema. Amlodipine and felodipine are safe in heart failure. Nicardipine I-4 is used in hypertensive emergencies, including preeclampsia and aortic dissection. Nimodipine is used for cerebral vasospasm after subarachnoid hemorrhage. Diltiazem sits in the middle, used in angina and hypertension with less myocardial depression than verapamil, but still requires caution with beta blockers. So take a breath here. Hypertension is not about memorizing drugs, it's about thinking clinically and protecting organs before damage happens. If this lesson helped you understand the topic clearly, like the video, share it with a friend who's preparing for exams, and subscribe so you don't miss the next part. In the next video, we move to the opposite side of blood pressure, hypotension and shock. That topic saves lives. Stay focused, keep going,